this might be Dr. Prosper here on his iPhone. Let's see, I see him connecting. There we are. Hi, Dr. Joey. How are you doing, Dr. Joey? Oh, you're muted there. Can anyone hear him? Dr. Joey, I think you might be muted or connected to headphones. I cannot hear you. Well, while we wait for Dr. Joey to figure out his audio situation, I did want to mention kind of what's on the screen here. So as a team, we are working to raise awareness about donations for Ukraine and specifically for healthcare workers in Ukraine. And so as you can see on the screen, we're donating urgently needed funds, specifically in reference to providing medical aid. And so here is a link that I will copy if you can see. It's the rotaryhealthprofessionals.org/donate. And that is one way that you can donate to Ukraine. And then another way that you'll be able to donate is by supplying specifically medical equipment. And so if you're interested in that, you can definitely reach out and we will tell you kind of next steps of where and how to donate physical medical equipment. Dr. Good or Dr. Pekya, is there any note that you'd like to make in reference to donating to Ukraine?
I might state that this goes to the English Rotary, and there really is no extra charge on it. All the monies you give go directly to English Rotary. They transfer it to Polish Rotary, and Polish Rotary, of course, right on the border with Ukraine. They purchase things there and get them across the border into the Ukraine. And Rotary is very good in terms of honesty. So there isn't any taking off the top for anything else here. And also for camaraderie. Dr. Phillips, who's head of the Rotary in England, connects with Poland, connects with Ukraine. It's a very nice way to get your donation into the Ukraine. And as we all know from the paper every day right now, these supplies are flowing into Ukraine, keeping it not only viable, but perhaps actually winning. It's amazing. But the giving of these donations are all medical and not military. And for example, the last plea I had was for a special CT for shrapnel. It's called a shrapnel CT. You go through it and it picks up the shrapnel, and then you certainly take it out. But I've donated here, and if you want to donate to Ukraine, this is a good way to do it via Rotary.
Thank you.
Okay, can you hear me now?
I can hear you, Dr. Prosper.
Okay, perfect. Wonderful.
Well, I'd like to go ahead and introduce Dr. Joey. And first of all, thank you, Dr. Good, for sharing that opportunity with us all. I'm the medical director of Global Offsite Care and help coordinate global grand rounds. And I'm also very honored today to be able to present Dr. Joey Prosper, speaking to us on telemedicine as a disaster relief tool. A little bit about Dr. Prosper. Graduated at the National Autonomous University of Mexico School of Medicine, did his residency there as well, and a subspecialty in minor surgery at the Hospital Albert Schweitzer in Haiti, and a subspecialty in homeopathic medicine with Homeopaths Without Borders. He's the pre-op doctor for the Comfort Naval ship when it's in Haiti. He's also a faculty member of the University of North Dakota School of Medicine. He's been practicing telemedicine since 2010 and won first prize on the telemedicine contest with the American Telemedicine Association, along with the LifePath Global Alliance. Welcome, Dr. Prosper. Thank you so much for joining us again. The floor is yours.
Thank you. It is so great to see you guys. It's always a pleasure to be with you. And Dr. Good, it's good to see you again.
Good to see you, Joey.
Yeah, I have learned so much. I have learned so much in the past 4 years when I've been going around. It's always a pleasure to at least give a little back. All right. So are we ready for the slide?
Yes, you can just let me know when to advance. So I'll begin here.
Okay. Yes, you could start with the first one. Okay. I want to share with you how telemedicine has been an essential tool for me for disaster relief. As you know, Haiti has been the subject of earthquakes and many hurricanes and so forth. But the last earthquake that we had, that was last August of 2021, and it happened in the south of the country. Okay, please go ahead. Next. Okay, so these pictures that you're seeing here, right here, it's in a hospital called Ofatma Hospital in Lakai. Lakai is in the south of Haiti. So I had to respond. When I first went there, I went physically. There. But keep in mind, unfortunately in Haiti, there's probably 2 or 3 of us doing telemedicine. And I'm probably the one who's doing telemedicine constantly. So in able to cover different areas, different hospitals, what I did is that I went there physically and my staff, part of my staff stayed in the area, and then I go to another hospital and another part of my staff stayed. So I had divided my staff into 4 groups, and each 4 groups had telemedicine tools with them, and they stayed in the area. While staying in the area, now we start by doing a triage. When we do a triage, as you already know, we choose who is most urgent that we can help. It makes no sense to choose somebody who's the most urgent and yet you can't help. So we choose whoever's the most urgent that we can help. Okay? All right. So now let's start with the device that we use and how we use those as a disaster relief. Next. Okay. This one particular patient, okay, you could go back a little bit. I think you skipped right here. This one particular patient had a neurological disorder, okay? And I could not identify what it was. And it was thanks to a neurologist that I've collaborated with in many times in Canada. And he gave us some times, and again, through telemedicine. And this man, he had some fracture in the lumbar region, but it was really the pinched nerve that was his main issue that gave him the semi-paralysis that he had. So with the help of that neurologist in Canada, we were able to help them. Again, telemedicine. Go ahead, the next one. Okay, these are images of my staff treating patients during the earthquake. While I was in the other side, I was in back at my clinic, and I had a few other doctors with me back at my clinic. Continue. All right. So now, this image right here, it's a digital otoscope. With this digital otoscope, which is what I use, so I'm called. We have a child who has who's not hurt physically, but had some hemorrhage coming out the ear, right? And so with this digital stethoscope, I did not need to do an ultrasound of the ear. And besides, we were right on place. There wasn't time to do so many things. But with that, with my staff right there with me, right? We took the images, we shared the images, we find out what the child had. We knew what part, because of this, we knew what part of the ear had the lesion, was fractured. And from there, we knew what kind of treatment to do. We had to do a local and systemic treatment for the child using this. This child who had a trauma injury of the ear, and with this device, we were able to sit, and it was quite easy for us to make the diagnostic and treat the child. Next. Okay, again, that's another image of the same kind of equipment. You don't necessarily have to have the same equipment that I'm using, but I made it my work as well to know which equipment works well and which equipments are better to use in the field. And this is again one of them. And this right here, I have my assistant in the field with their telephone, and it's from their telephone they are sending this to me, you know. And sometimes they send it via WhatsApp, sometimes via Zoom, or which another app. But all of them works well, and with that trauma was able to identify. Next. Okay. All right. Now, what am I using on the field? This is the iPad that I use. I have my staff use, and again, thanks to Global Grand Round, I have a brand new iPad. My previous one were giving some trouble, and this is what we're using right now. So with this iPad right here, right, and I could share screen with all my materials, with all the equipment that I'm sharing with you. Now, how about electricity? For electricity, this is an inverter. This is the inverter that I use, and this inverter, it comes with a solar panel. So while I'm in the field, as long as I have a little bit of sun, I'll always have electricity. If there's no sun, this can it can charge. It can stay charged for about 16 hours. So this is the perfect tool to have electricity while you're in the field, whether it's when you have a disaster relief problem or a hurricane, whichever it is. This works perfectly for me. Okay. At the end, if anyone wants to know the name of this, how to get it, they could ask me, or they could ask anyone from Global Grand Round, Alexandra, and I'll share it with her. Next. Perfect. So now we have this dermatoscope. Okay. With this dermatoscope, it helps me whether it's disaster or not. I'm able to identify. But more so, I don't know if I have one of these images here. More so, where this works perfectly for me is that it helps a lot of times. I cannot place or identify very well when we have some inflammation. And for example, if I have some inflammation near the joint, and sometimes it might be a little hard for me to tell whether it's a joint liquid that is in that area, or is it just pus from an abscess or something of the sort. And the orthopedic surgeon who's next to me while we are seeing patients and doing triage and so forth, this is a very good tool. From there, we'll identify, we'll have the nurse say, okay, we have this inflammation right here. Okay, ask the patient to move his toe, his legs, or whatever. And from there, with the touch of the nurse or the assistant, and with these tools, we can identify whether the bone is broken or not. And later on, you'll see with this also, with the butterfly IQ, that could also help us while doing that. Next image. There we go, the butterfly IQ. Okay, and as Dr. Gu and the team knows, I've been using this for a little over 2 years. It's one of the equipments that I'm very happy with. Now, with the butterfly IQ, it allows you to select the different sub areas or organs that you want to do. So again, when we have the fracture while in the field with the butterfly IQ, we can tell with the butterfly IQ when we select bones, and you'll see the images on the bone. It won't be like an X-ray, but you could see it. You could see it in the sense where you'll be able to see if the bone is fractured, if it's ruptured, what might the bone have. And from there, a decision can be made. Will this patient need surgery? Or is this patient, whatever fracture that this patient has, is it urgent, or can we wait a little? Can we put somebody else in front of that patient for surgery? And also, what the butterfly IQ also allows you to do, it gives you the ability to see blood circulation. Therefore, you can see whether or not there is a hemorrhage in certain areas, and that will tell you about that. So for me, when I got the butterfly IQ, when I first started using it, 2 months later, I knew I had to teach my staff how to use it as well. And in that, it's more important that my staff knew how to use it well than I did. Although I'm always playing around with it. But this, whenever we had, whether it was a hurricane, for that last earthquake, that was a great tool to identify whether it was orthopedic, whether we had a suspicion of internal hemorrhage or anything of the sort, you know. And with the butterfly IQ, we were 4 times faster with most of the other with a stable ultrasound that the hospital had, and we were a lot faster to identify the cases and send the case to referrals. All right, next. Okay, I think there are 2 other images that are missing. Can you keep going? We have the digital stethoscope as well. Keep going. All right, but anyway, let me tell you. So one of the things that that we use as well, we have the digital stethoscope. But if you're gonna be out in the field, make sure that you have a digital stethoscope while your staff is out in the field. Unfortunately, I don't have the pictures here, but I can tell you what it is. And then, you know, the Echo digital stethoscope that can register the sounds and with the images. So it's plugged to your telephone, especially with the iPhones, right? And you could have the visual. You could have the visual of the person's cardiac rhythm. You could also have the visual of the stats and the numbers, okay? While you can listen to it as well. So what I do as a practice, I have my staff use a small speaker, and with that small speaker, you know, it's good enough for me to hear the person's heartbeat, and also what it does, it gives you a graphic of the person's cardiac rhythm. It is almost as an electrocardiogram. It's not quite that, but at least with that graphic, you'll be able to tell, you'll be able to identify a lot of cardiac issue that the person might have. Okay, so now what do we have? We have a digital stethoscope, we have a digital otoscope, we have a digital dermatoscope. All of these equipment are connected to your iPad. I can't tell if it's if you are able to use it in other tablets or things that are not Apple. I made it a habit to use Apple because most of the equipment, medical equipment, are usually compatible to Apple. So I can't tell, but if anyone wants to know, I can research for them. I know Butterfly IQ now. They also do other equipment beside Apple. So with all these equipment, and what do you have? You have electricity with the equipment that I show you. You have electricity up to 16 hours charge. And if you have, if there's sun out there, you don't need to use that charge because it will be using the electricity. So let's say, for example, there's sun, and then you have that backup. So you have electricity for more than 24 hours, and you can be recharged with the solar panel. Okay, and it's not an expensive equipment. I've only had it for the past 4 months. It only cost me $204, which I'm very happy with. Now, so you have all these equipment, but another thing that is very important for you to do, for your staff to do, and make sure, whether it's your nurse, if you're practice medicine, whether it's your nurse or whether it's your telemedicine assistant, what helps a lot, 50% of the equipment, 50% of the use is the equipment, but the other 50% is your staff. Teaching your staff how to use your hands, and so that they can replace your hands with their hands. By having your staff knowing how to use the hands, knowing how to do the proper touch in the body and giving you the proper response, that is the key element. Excuse me. And with that element, even with the least amount of technological equipment, you know, you will be able to do so much. So I think it's extremely important. And trust me, if you have your telemedicine assistant come to your clinic. When you are seeing patients, you teach him how you do the touching on your patient, whether it's abdominal, whether it's different parts of the body, that is key. And then you practice with that the telemedicine assistant while he's in the other side. Have him seeing a patient. It could be in the same clinic. You stay in one room, he's in the wrong room, and have him do whatever you want him to do and see what the response is, and then you'll know when that person is ready. That is a key element. For me personally, it has worked great. Okay. And so what I'm gonna do, I'm gonna leave a great amount of time for questions because that also is very important. And I think there's a lot of thanks to the questions that I can share with you. I must say that I have done a lot of disaster relief in Haiti. I've been in disaster relief in Haiti at least in 6 occasions, in the past 4 years. Unfortunately, that's what Haiti has gone through. I've been in 2 in Africa, in Burkina Faso and in Ghana, and I've been in 2 in New York also. It was in Rochester, New York, and in Queens, New York during the big flood and so forth. All right. So I leave. If anyone has any question or anything, I'll be happy to answer them.
Thank you, Dr. Joey. That was wonderful. Yeah, opening it up for questions.
Okay. If there aren't any more questions, if there are any questions, then meanwhile there are a few things I can share. Yes, go ahead, Dr. Good.
Hi, Dr. Joey, great presentation. I like your emphasis of not yourself, but the people you work with, your assistants, being able to do the equipment and so forth.
Correct.
We have the same thing. And in our ICUs, we have critical care nurse practitioners. We have used this equipment with us by telemedicine. And the more you have them do, the better it is. I agree with you.
Yes.
Your assistants.
Yes.
And here's the question.
Most
what do
definitely.
you do about blood work? Do you have any way of doing the following? Because you can do a blood sugar pretty easily.
Thank you.
What about a blood gas? And what about a panel?
Okay, thank you. So, of course, you can have a limited amount of blood lab, but we also have a lab. We also have a lab that goes with us. And Dr. Good, what the lab needs the most for them to be able to practice in the field is electricity. I'm saying they have the equipment. So what they have, let's go back with the equipment. What does the lab need? They need the centrifuge. They need the microscope. I find these 2 elements are the most that they need to go on the field. And from there, for me to get certain blood panels, if it's malaria, if it's typhoid, if I want to have a hemoglobin count, for example, I have a patient who had a fracture, who lost a lot of blood, right? And I want to know what's the hemoglobin count. Right there, we have the centrifuge, we have the microscope, and we have the tubes and everything, and I'm providing electricity to my lab technician. Guess what? In less than an hour, I'll get the result of that hemoglobin count, and I will know whether or not this particular patient is anemic, has lost a lot of blood, or is in the level. Let's say the person blood hemoglobin is less than 5. We have to get that person a transfusion, and that makes a huge of a difference. So thank you for asking that question. Yes, it makes a huge difference. So again, let me emphasize a little bit more on that because that was a great question. It's one of the things that I should have pointed out, but I did. So you can have a small lab going on the field. You speak with a lab technician, you'll be amazed what this person can do having the centrifuge, the microscope, and the tubes. That person will be able to do blood counts, malaria, typhoid, H. pylori exams, HIV, a whole range of exams that person will be able to do. So that person is going to ask you, how do you get electricity? And with that equipment that I just show you, my lab technician has electricity all the 12 hours. The last shift that we did, we were there for 12 hours at the hospital of Fatma, what I just shared with you in the image. So I had 3 lab technicians. At certain times, one of them would get tired and they would rotate, okay? And also, people, when you're in disaster relief, we are not Superman. And I have to say that to myself all the time. We are physicians, but we're not Superman. A lot of times, we think that we could go on for hours and hours and hours. We might, but hey, but you'll be surprised, and things that you probably would have done differently after 16 hours, you know, working in a disaster relief, because you work very hard, you're going up and down, you're walking a lot, you know. So always have one of your doctors rest and do rotation. Try to do a shift rotation. I wouldn't say every 8 hours, but every 6 hours. Because right there on the field, it's different. It's not like being in your clinic or in the hospital. You are going up and down, and a lot of times you find yourself running, not just walking, but running. Okay. Do you have any questions?
Another question. What do you do about, do you have a medicine pack that you have in terms of you make a diagnosis? Do you have penicillin, ceftriaxone, let's call it lorazepam, etc.? But do you have a medicine kit that you can just prescribe right then?
We always have a medicine kit for disaster relief. We always have it. Just like we always have, for example, in Haiti, Dr. Good, I always have a kit in my car for the simple reason. So many times you're driving through an accident and the ambulance is not going to show up, or if he's going to show up, it's probably going to be 1 hour or 40 minutes. So you always need to have a kit. We always, for example, in our case, because so many disaster relief, you know, we have, let me show you right here. We have something similar to this that looks like a closet, which is specifically for disaster relief. This is not used for anything but disaster. Yes, it has antibiotics, it has syringes, it has anti-inflammatories. We have a defibrillator in there as well. And you know, different hormone medicine in case the person goes into shock and, you know, things of the sort. Yes. So, oh yeah, that's very important, because you have to bring your own pharmacy. You have to have a mobile pharmacy with you as well when you go to the area. We were lucky at that time when we went the last disaster relief. Most of the patients were brought to Fatma Hospital, to that hospital. But this is not. That wasn't always the case. In 2 days later, we find ourselves in a soccer field providing care to these people. And in that soccer field, we have to have our mobile pharmacy with us.
Thank you.
Yes.
Dr. Joey, thank you again. That was absolutely fantastic. Let's keep it going. I have a question about logistics, cost, and getting specific. For your complete pack, everything that we described, and if we could create a starter kit that helps replicate what you're doing and make it scalable, what's the actual cost per pack, and what is your budget on that per pack, and then also getting this equipment to the places that it's needed the most, the logistics of shipping and so forth. So it's about funding and about the logistics of getting it to the point of care. What's been your experience with that, and what are the price points?
Okay. I'm always happy when that question is being asked to me. One of the reasons I was granted a type of scholarship two years ago after I did a writing with the Butterfly IQ, and I went to it was in Queens, New York, where I was invited to where I was given a scholarship to do a subspecialty in ultrasound of the articulations and so forth. And everyone, they had all the other students, they had their beautiful, nice looking ultrasound machines, and not one of them cost less than $4,500, right? And at the end of the practice, at least 4 of them, we were a group of 16, at least 4 of them, right in front of me, to Amazon, they ordered their Butterfly IQ. which costs about $2,000. And so the Butterfly IQ is the most expensive of all the equipment that we have in the pack. Altogether, what I showed you, and included the electricity backup tools, I would say it's around $3,800 altogether. That's the cost. And with that, now I don't have a specific price for the lab, because what they're using, the lab materials is the same. It's not any different than the other lab materials that you would use. The only thing is you're gonna bring something that is reasonable in electricity, like I said. So I wouldn't say, if you're gonna add the price for a microscope, for the tubes and for the centrifuge, I'm not sure what that would be. But without the microscope, without the lab equipment, we're looking at around $3,800. Yeah, and I'm saying this. I'm not one of those who have these equipments and don't have use for them. No, not in Haiti. Not in Haiti. You're always gonna have use for them. Unfortunately, hurricanes always hit us hard, and we've had at least 8 big disaster relief in the past 4 years, but I was present for 6 of them, because the other 2 I was out of country. But nevertheless, I did assist to telemedicine. Okay. I can't hear you.
There we go. Sorry.
Yeah.
One more
Yeah, I can hear you
question
now.
on logistics. You mentioned the equipment, the training, electrical power. Are you able to deliver services if your internet is spotty or non-existent? Can you run autonomously on power, equipment, and maybe intermittent communication for your telemedicine support?
Okay, I've had, for example, I've had situations where the internet is not so good. The good thing about Haiti, wherever you have a good telephone signal, you could have internet. But I've been in places where the internet signal is not so good, so then I can't do Zoom because what it takes. But guess what? I do WhatsApp. WhatsApp takes less waveband, and I do WhatsApp, right? And then I could get just about the same results, And but wait. Now, I have been in there sometimes. There was a time we went to that soccer field, right? I was there for the first 3 hours, then had to go to another site. When I got to the other site and I'm trying to do telemedicine with them, guess what? There's no internet. There's connectivity for telephone, but there's no internet. So what I did, I went to the telephone, so I called my telemedicine assistant, right? And we were doing just a lot of things to telephone, just to the phone calls. We were able to do a lot of things. And anything else that I felt that I wasn't comfortable in doing, I left it up to the other doctor that was there. But to the telephone, I told him, and this is somebody who've learned, who I've got his hands, to be able to see patients. Therefore, I trust him. I know he has the right touch. We've been doing this for years. So I would ask him, how does it feel? What this is like, how this goes about, And from there, I'll be able to say, okay, this is what we're gonna do. Let's prescribe this, let's do so and so and so. And ask him, okay, what do you get from with the images? What does it show? What is it showing? Okay, for instance, he'll do an ultrasound for me. I don't have any internet. Guess what? He sent it to me on WhatsApp, right? And this patient, we stabilize the patient, right? If we think that the patient is urgent, then we send the patient to the ortho or wherever. But if we feel that it's not an emergency, so that patient is stabilized, and we wait until we have internet. Where I'm in another place, I have internet, and where the telemedicine assistant have internet, right? So whatever he sent to me on WhatsApp is loaded, then I can conclude and then go back to that patient.
Mm-hmm.
And these are the kind of things that we're able to do. So there are so many things we could do with that. Yes.
Great, thank you.
Okay. I think there was somebody else who said they had a question. Okay. So
Joey,
I
question.
actually, okay.
Question. Do you have any ability to handle, for example, a physician or let's say an advanced medical student who'd want to come and spend some time with you, and if they had finances to come in terms of the experience and so on, I think this would be invaluable to young doctors.
As a matter of fact, you're right. And that's what I do at the University of North Dakota. At 1 o'clock, I'm gonna have a group of students in clinic rotation with me while I'm in Haiti. And we do the same when we go to mobile clinics. And with the disaster relief, the neurologist that I told you about who helped me out, and he asked me, can some of his students assist? I said, yes. And they were so grateful. So most definitely, yes. So right now, we have the ability to do it through telemedicine, but also if they want to come physically with us and assist us, of course. As you know, Dr. Good, I love doing mobile clinic, and I do mobile clinic once a month. I go to the far rural areas of Haiti, and it's just great. It's a great experience. It's these kind of things that reminds you of medical school, and you go back and say to yourself, this is the reason why I went into medicine. So the experience is always rewarding.
We have a telemedicine course for medical students, and it's conducted.
Great,
I'll
great.
contact you, and we'll see if we can join you in your clinic. There's usually 4 to 6 students, and we can do this by Zoom. And I'll contact you. We'd love to have our students join you in terms of that clinic. It's a wonderful teaching opportunity. It may get some of them to do Schweizerian type work.
Yes. That would be great. Yes, I'd love that.
I'll contact you.
Okay. Thanks, Dr. Good. Yes, somebody else?
Yeah, I actually have a question. I am working with Global Offsite Care to try and establish a telemedicine team in Beirut, Lebanon. And so they experienced the explosion in August of 2020, I believe it was. And so their hospitals were completely destroyed. And telemedicine, specifically with the group that I'm working with, has never been established before. So I was wondering if you had any advice on how to, create an effective telemedicine team from the start. What's the key to getting telemedicine to a location that's never had it before, with individuals and healthcare providers who have never worked with telemedicine before? Do you have any advice for starting up telemedicine?
One of the things that you want your physician, your head physician, you want your physician to have some experience in teaching. You want someone like Dr. Good, which is going to be extremely rare. Okay, so we won't get that. So let's go elsewhere. That's not going to happen. But what you need somebody who has experience in teaching, because that person will be teaching his assistant. No matter how experienced the person might be on the telemedicine assistant or a nurse in telemedicine, for each physician, it's a little bit different. My style of practice might be different from one doctor to another doctor and so forth, and this is how it is. And and us doctors, unfortunately, sometimes we think that we're semi-gods, and we tend to want the people to do it our way. So that's the first thing. You want to have a doctor who's experienced in teaching, or at least who likes teaching and be able to teach the staff. And you want to have a staff who's willing to learn, and you have to have a person who's good in technology. It's very important that you have somebody who's good in tech, and also you need to have a staff who's also quick for rapid response.
Mm-hmm.
What happens is that otherwise it's gonna take you an hour to see one patient, and that won't be practical once you are doing disaster relief. Okay, so Find out what do they like. Okay, so they might want to have you. They might want to have a mobile pharmacy. They might want to have a mobile lab, just like I stated right now. Now, for the mobile pharmacy, it might be different from most of the medicines that I would use, for example, in Haiti, is not necessarily the same medicine I would use in certain areas in the Middle East. So you'll probably want to find out what are the most frequent diseases, and whatever, if it was a bomb, whatever happened in that area, or the people are still are having more skin issues, more respiratory issues. And from there, you might select the medicines that you want to have in your mobile pharmacy. And I personally, I like having recent graduated nurses or telemedicine assistants. Don't get me wrong. If you have a nurse who's dedicated and want to do this, that nurse could be fantastic. However, a lot of times you find nurses or even doctors who are already intoxicated with certain systems that they have and don't want to change, and don't want to follow protocol as it should. And so that's the advantage that you usually have when you have a new graduated nurse or physician, or things like that. Now, as for your head physician, you don't want them to be a new graduate. You want someone that is experienced and that has some experience in teaching. But if that person wants to have an assistant, the best assistant I find is a newly graduate.
Okay, that's really great advice. So specifically for the team in Lebanon, they're trying to implement telemedicine in the ICU of a hospital that they're rebuilding. And so the thing with Lebanon specifically is a lot of the doctors no longer practice in Lebanon because of the situation with the economy. So they move abroad, and we think that it would be beneficial to implement telemedicine with doctors who are abroad but have trained staff in the ICU.
Well, let me share a little something with you about Rochester, New York. So one of my colleagues, Dr. McConaughey, who's a pediatrician, and he helps me also with the kids when I'm the kids at the orphanages. So Dr. McConaughey, about in 2012, the same year that that was the same year that I won first prize with telemedicine practice with the American Telemedicine Association, and I met him to another connection, and they sponsored a grant for him for $20 million with the University of Rochester, right? That's what I said. We need that around here in Haiti. So anyhow, the grant was $20 million to do a telemedicine trial. It was a pilot program. They did it, and they did it mostly with kindergartens, right? So they were overseeing various kindergartens, and when a child was sick, through telemedicine, they had a telemedicine assistant who's a nurse, and that telemedicine would convey with Dr. McConaughey, and from there, they would find out what's wrong with the child, and there was a pharmacy, and from there they would call the mother of the child or the parents. They would let them know, okay, you know what, you don't have to leave work and bring the child to the hospital. Our doctors have seen the child, the prescription is there, and so forth. So the pilot was a great success, right? 2012. That program was never implemented at the hospitals, the University of Rochester hospitals, and that is was very depressive for Dr. McConaughey. And when he told me about it, it was somewhat upsetting, because the pilot was a great success. It showed that the diagnostic at 99.2% is the same, whether he was doing telemedicine or whether it was physically there. Dr. McConaughey, he even wrote a paper about it, And so why wouldn't they implement telemedicine in the hospitals? Until COVID came, they had no choice. Their ICUs were overwhelmed with patients. Well, let's see it that way. A telemedicine visit costs between $70 and $80. once a person stepped into the emergency room at the University of Rochester Emergency Room Hospital, that's automatically $800. So uh, telemedicine has been a great success. The reason why it hasn't been implanted in so many hospitals throughout the US is economics, you know? And it's, for example, in that case with University of Rochester, it's $800 versus $70 or $80.
Sure.
Yeah. Okay.
A comment on our grand rounds coming up on May 25th. We're going to talk about telemedicine rapid response protocols. So this would be something right up your alley. And
Oh, yeah. That's something I definitely want to watch.
So I'm going to try to get Lebanon involved too. That's the topic.
Yes. So imagine, Dr. Good, a month ago, I was approached by a group because Rochester is like my second home. I was approached by a group, and the staff, they said they don't have salary to pay me, but they'll put me in a plane and pay hotel and things like that for me to come to Rochester to speak with a group who wants to implement telemedicine over there in Ukraine, you know. And that's what I did. I told them they didn't have to pay hotel because we have a place in Rochester where we could stay. So in a church in Rochester for 3 days, it was a Orthodox church, and we were doing teaching on telemedicine and how they can implement telemedicine with doctors who are in different cities or in different places like Poland and so forth in Europe and even in the US, how they can apply their medical skills and help, people who have been affected by the war in Ukraine. So this is how effective telemedicine is. This is how sound it is. Yeah.
So did the conference turn out pretty well? Participation and so on?
Well, so far they're practicing and they think the result is very well. It's good.
Okay, very interesting.
Yeah.
Another question. This is really specific, Dr. Joey, to the specialty panel. Basically, your experience with having specialists across the typical specialties that you might need to engage on a telemedicine encounter. What's been your experience with the availability of remote telespecialists to assist you in your efforts in a disaster zone and for your ongoing telemedicine practice?
Okay, so when I need help, when Dr. Good is not available in the years I've made, or when some of my other physicians, I have a group of about 6 or 8 physicians with different specialists who assist me. So whenever I go anywhere, there are whether it's a medical conference or anywhere, and there are some specialists that I need that I haven't, and I need the support of that specialist for my patient. And I'm grateful because at the end of the day, it's not, my practice is not economically rewarding at all, but it's extremely rewarding. And I'm grateful for that. And it's never about me. So that's what I'm grateful for. So whenever I see a specialist that, for example, the last time I met a neurosurgeon and I told him, listen, how would you like to come to beautiful Haiti with me without leaving the comfort of your own practice or office? So that's that's my approach. Yeah. And so you'll be surprised how many people, doctors in general, always want to help. I'm saying I can brag about this as a physician. We are humanitarians. Doctors always want to help. You ask this person, I'm looking for a specialist who can assist us. Give us perhaps 1 hour a month, and so you will be able to find a lot of physicians, especially if you have a 501c or 501c3, or if you are a partner with a person who has a 501c3, and you tell them, guess what? For that 1 hour, you could charge whatever we could give you a receipt as a 501c3 for what you usually charge, you know? And the response is usually, why 1 hour? I could give 4 hours a month. I could give you 8 hours a month, you know? So that's the usual response, you know?
Mhm.
And so for me, I don't know for other groups, I've been grateful to be able to find different physicians with different skills who have provided their times for me to telemedicine to help different patients in Haiti.
What specialist do you need most?
Right now or in general?
No, but if you give a panel, do you need cardiology first, endocrinology, infectious diseases?
The internist and family practitioner are always the top ones, because
Okay.
these are the ones we want to have first, and then they'll refer the cases, because they'll see everyone, like yourself, like myself. We'll see everyone, and if it's something to our limited knowledge, then we either consult some specialist in that knowledge, or either have if that person is in our panel of specialists, we get in contact with that person and give a new appointment to the patient, and so forth.
Great, thank you.
Okay.
Okay. All right, we're coming up toward the end of the hour. You want to go ahead and close any closing statements?
Yeah, I want to add something. What I want to add is this: we don't undermine the capability of your assistants. Don't think that I could teach them that, but they won't be able to do it. I'm unsure of that. This has been my experience, where we have a lot of physicians who feel that if they're not there physically themselves, their assistant won't be able to do this. So that's something you'll be surprised. Don't undermine it. And you might have some assistants sometimes who have better touch than we do, you know.
Yeah.
And so be humble about it, and please remember, it's not about you. It's about your patients. Always make the decision that is best for your patients, and don't be timid or shy to share your skills with your assistants. So that's really what I wanted to say.
Great. That is, so valuable. We appreciate your advice. This is immensely helpful to many of us. And unless we have any other questions, I'd like to thank you again, Dr. Joey, for sharing your time and experience with us.
Always a pleasure.
Back to Alexa.
It's always a pleasure.
Yes, thank you, everyone. I appreciate you so much, Dr. Joey. If anyone is interested in presenting here at Global Grand Rounds, feel free to reach out to me. And if you would like CME credits or have any questions or would like to see the presentation, I'll put my email in the chat. But thank you, everybody.
How would you like to end with a poem? Would you like to end with a poem?
Yes, let's do it.
Yes.
Ready? Okay, now I give this
yes,
poem for a reason. This is by Rumi. Rumi was 1207 to 1273, 13th century. He was born in Afghanistan. He lived for a while in Iran, but he actually lived in Turkey. And you can visit his tomb in Turkey, okay? And I think he's one of the best poets to help people resolve issues. And I'm going to use the word reconciliation, okay? How do we forgive the Russians? How do we forgive the Germans? How do we forgive ourselves? And this is a poem about being able to reconciliate, not forgive, reconciliate. It's very interesting. Here it is. Okay. This is called Out Beyond Ideas. Do you have the poem there to show? Why don't you put it up? Because I snuck this in on you. Because I think we'd like to end on a poetic note.
Let's do that. I'm pulling
okay,
it
here
up
we are. It's a very simple poem, but this is a very good poem. It helps me whenever I want to reconciliate something, like my son gets divorced, I give him this poem. All right. Okay. It's Out Beyond Ideas. Okay. It's coming up in a minute here. Okay, here we are. Out Beyond Ideas by Rumi. I've given you his dates. Here it is. Out beyond ideas of wrongdoing and right doing, there is a field I'll meet you there. When the soul lies down in that grass, the world is too full to talk about. Ideas, language, even the phrase each other doesn't make any sense. Who's right and who's wrong? That's what this poem's about. And everybody thinks they're right and everybody thinks someone else is wrong. But this is a way of reconciliation. Get beyond the ideas of wrongdoing and right doing. And I want to share that with you. I think it's a very nice poem.
I would like to
John, you
share
have any
something.
idea on this? Yes. Please.
Yeah, I like to share something. This is a very short poem, and that I always keep to myself. And I forgot, Dr. Good, you always end it or start your sessions with a poem. So let me share this one with you. It's a very short one. It's about beauty. All beauty is beauty within beauty. What kills beauty is comparisons. I'll repeat it again. All beauty is beauty within beauty. What kills beauty is comparison. This is a poem from a voodoo priest called Leonard Joseph, from a Haitian voodoo priest. His name is Leonard Joseph.
A great note to end on.
Beautiful.
Yeah.
Beautiful. Thank
Okay.
you. Thank you.
Okay, see you all.
Thank you so much,
Greg,
everyone.
yeah.
Thank you, everyone.
Bye.
Bye-bye. Thanks, Joy.
Okay.